Hyperthyroidism. Thyrotoxicosis is defined as the state of thyroid hormone excess and is not synonymous with hyperthyroidism, which is the result of excessive thyroid function. However, the major etiologies of thyrotoxicosis are hyperthyroidism, caused by Graves' disease, toxic multinodular goiter, and toxic adenomas. Similar to hypothyroidism, there are a lot of causes of thyrotoxicosis, but primary hyperthyroidism still accounts for majority of cases. In primary hyperthyroidism, the thyroid gland is producing excess amount of thyroid hormone. The elevated T3 and T4 will send negative feedback to the hypothalamus and the anterior pituitary. Since the anterior pituitary is normal, it will respond by decreasing the TSH level. However, in spite of the low level of TSH, there is still a continuous secretion of excess T3 and T4, giving us a biochemical picture of a low TSH and high T3 and T4 in primary hyperthyroidism. In secondary hyperthyroidism, the high thyroid hormone secretion is due to the overstimulation coming from the pituitary or the hypothalamus, giving us a biochemical picture of an elevated T3 and T4 in the presence of an elevated TSH. Among the long list of the causes of primary hyperthyroidism, Graves' disease accounts for 60 to 80% of thyrotoxicosis. The prevalence varies among populations, reflecting genetic factors and iodine intake. Graves' disease occurs in up to 2% of women, but is 1/10 as frequent in men. The disorder rarely begins before the adolescence and typically occurs between 20 to 50 years of age, but it also occurs in the elderly. Similar to Hashimoto's, the underlying pathophysiology is an autoimmune process. Environmental and genetic factors including polymorphism in HLA-DR, the immunoregulatory gene CTLA-4, CD25, PTPN22, FCRL3, and CD226, as well as the gene encoding the thyroid-stimulating hormone receptor contributes to Graves' disease susceptibility. Indirect evidence suggests that stress is an important environmental factor, presumably operating through neuroendocrine effects on the immune system. Smoking is a minor risk factor for Graves' disease, but a major risk factor for the development of ophthalmopathy. Sudden increase in iodine intake may also precipitate Graves' disease, and there is a threefold increase in the occurrence of Graves' disease in the postpartum period. The hyperthyroidism of Graves' disease is caused by thyroid-stimulating immunoglobulin that are synthesized in the thyroid gland as well as in bone marrow and lymph nodes. TSI can be detected by bioassays or by using the more widely available thyrotropin-binding inhibitory immunoglobulin assays. The presence of thyrotropin-binding inhibitory immunoglobulin in a patient with thyrotoxicosis implies the existence of TSI, and these assays are useful in monitoring pregnant Graves patients. Thyroid peroxidase and thyroglobulin antibodies occur in up to 80% of cases. Because the coexisting thyroiditis can also affect the thyroid function, there is no direct correlation between the level of TSI and thyroid hormone levels in Graves' disease. Thyrotoxicosis may cause unexplained weight loss despite an enhanced appetite due to the increased metabolic rate. Other prominent features include hyperactivity, nervousness, and irritability, ultimately leading to a sense of easy fatigability in some patients. Insomnia and impaired concentration are common. Apathetic thyrotoxicosis may be mistaken for depression in the elderly. The most common cardiovascular manifestation is sinus tachycardia, often associated with palpitations. The thyroid is usually diffusely enlarged to 2 to 3 times its normal size. There may be a thrill or bruit due to the hypervascularity of the gland and hyperdynamic circulation. Fine tremors is a frequent finding. best elicited by having the patients stretch out their fingers while feeling the fingertips with the palm. Ophthalmopathy and dermopathy are specific for Graves' disease. The clinical presentation depends on the severity of thyrotoxicosis, the duration of disease, individual susceptibility to excess thyroid hormone, and the patient's age. In the elderly, features of thyrotoxicosis may be subtle or masked, and patient may present mainly with fatigue and weight loss, a condition known as apathetic thyrotoxicosis. Graves' disease is associated with specific eye signs that comprise Graves' ophthalmopathy. This condition is also called thyroid-associated ophthalmopathy because it occurs in the absence of hyperthyroidism in 10% of patients. Most of these individuals have thyroid antibodies. The onset of Graves' ophthalmopathy can occur within the year before or after the diagnosis of thyrotoxicosis in 75% of patients, but can sometimes precede or follow thyrotoxicosis by several years, accounting for some cases of euthyroid ophthalmopathy. Thyrodermopathy occurs in less than 5% of patients with Graves' disease. It is almost always in the presence of moderate or severe ophthalmopathy. Although most frequent over the anterior and lateral aspects of the lower leg, hence the term pretibial myxedema, skin changes can occur at other sites, particularly after trauma. The typical lesion is a non-inflamed indurated plaque with a deep pink or purple color and an orange skin. Thyroid acropachy refers to a form of clubbing found in less than 1% of patients with Graves' disease. It is strongly associated with thyroid dermopathy that an alternative cause of clubbing should be sought in a Graves' patient without coincident skin and orbital involvement. The clinical features generally worsen without treatment. Mortality was 10 to 30% before the introduction of satisfactory therapy. Some patients with mild Graves' disease experience spontaneous relapses and remissions. Rarely, there may be fluctuation between hypo and hyperthyroidism due to changes in the functional activity of TSH receptor antibodies. About 15% of patients who enter remission after treatment develop hypothyroidism 10 to 15 years later as a result of the destructive autoimmune process. In Graves' disease, the TSH level is suppressed and the total and unbound thyroid hormone levels are increased. In 2 to 5% of patients, more in areas of borderline iodine intake, only T3 is increased and is termed as T3 toxicosis. Measurement of TPO antibodies or thyrotropin binding inhibitory immunoglobulin may be useful if the diagnosis is unclear clinically but is not needed routinely. The hyperthyroidism of Graves' disease is treated by reducing the thyroid hormone synthesis using an anti-thyroid drug or reducing the amount of thyroid tissue with radioiodine treatment or by thyroidectomy. The main anti-thyroid drugs are the thionamides, propylthiouracil, carbimazole, and metimazole. All inhibit the function of TPO, reducing oxidation and organification of iodide. These drugs also reduce thyroid antibody levels and they appear to enhance spontaneous rates of remission. Propylthiouracil inhibits the iodination of T4 to T3. However, this effect is of minor benefit except in the most severe thyrotoxicosis. Metimazole is the preferred drug for Graves' disease. Due to the hepatotoxicity of PTU, the US FDA has limited indication for its use to the first trimester of pregnancy, the treatment of thyroid storm, and patients with minor adverse reaction to metimazole. If PTU is used, monitoring of liver function tests is recommended. Thyroid function tests and clinical manifestations are reviewed 4 to 6 weeks after starting the treatment, and the dose is titrated based on the unbound T4 levels. Most patients do not achieve euthyroidism until 6 to 8 weeks after treatment is initiated. TSH levels often remain suppressed for several months and therefore do not provide a sensitive index of treatment response. Maximum remission rates are achieved by 12 to 18 months for the titration regimen. Supportive treatments such as beta blockers, coumadin, and digoxin can be given to control the other associated symptoms brought about by the hyperthyroid state. Radioiodine therapy is another option for the treatment of hyperthyroidism. Radioiodine causes progressive destruction of the thyroid cells and can be used as initial treatment or for relapses after a trial of anti-thyroid drugs. There is a small risk of thyrotoxicosis after radioiodine, which can be minimized by pre-treatment with anti-thyroid drugs for at least a month before treatment. Most authorities favor an approach aimed at thyroid ablation as opposed to euthyroidism, given that levothyroxine replacement is straightforward and most patients ultimately progresses to hypothyroidism over 5 to 10 years, frequently with some delay in the diagnosis of hypothyroidism. Pregnancy and breastfeeding are absolutely contraindicated to radioiodine treatment, but patients can conceive safely 6 months after treatment. Total or near-total thyroidectomy is an option for patients who relapse after anti-thyroid drugs and prefer this treatment to radioiodine. Some experts recommend surgery in young individuals, particularly when the goiter is very large. Careful control of thyrotoxicosis with anti-thyroid drugs is needed prior to surgery to avoid thyrotoxicosis and to reduce the vascularity of the gland. The major complications of surgery, such as bleeding, laryngeal edema, hypoparathyroidism, and damage to the recurrent laryngeal nerves, are unusual when the procedure is performed by highly experienced surgeons. Thyrotoxicosis or thyroid storm is another medical emergency. It is rare and presents as a life-threatening exacerbation of the hyperthyroidism accompanied by fever, delirium, seizures, coma, vomiting, diarrhea, and jaundice. The mortality rate due to the cardiac failure, arrhythmia, or hyperthermia is as high as 30% even with treatment. Thyrotoxicosis is usually precipitated by acute illness such as stroke, infection, trauma, diabetic ketoacidosis, or surgery, especially in the thyroid, or radioiodine treatment of a patient with partially treated or untreated hyperthyroidism. Management requires intensive monitoring and supportive care, identification and treatment of the precipitating cause, and measures that reduce thyroid hormone synthesis. Large doses of PTU should be given orally or by nasogastric tube or per rectum. The drug's inhibitory action on the T4 to T3 conversion makes it the anti-thyroid drug of choice. Thyroiditis. A clinically useful classification of thyroiditis is based on the onset and duration of the disease. It can be classified as to acute, subacute, and chronic thyroiditis. Acute thyroiditis is rare and due to suppurative infection of the thyroid. A long-standing goiter and degeneration in a thyroid malignancy are risk factors in the elderly. The patient usually presents with abrupt onset of thyroid pain, often referred to the throat or ears, and a small tender goiter that may be asymmetric. Fever, dysphagia, and erythema over the thyroid are common and are the systemic symptoms of a febrile illness and lymphadenopathy. The erythrocyte sedimentation rate and white cell count are usually increased, but the thyroid function is normal. Fine needle aspiration biopsy shows infiltration by polymorphonuclear leukocytes. Culture of the sample can identify the organism. Antibiotic treatment is guided initially by gram stain and subsequently by cultures of the FN biopsy. Surgery may be needed to drain an abscess, which can be localized by CT scan or ultrasound. Subacute thyroiditis is also termed as decurvain thyroiditis, granulomatous thyroiditis, or viral thyroiditis. Many viruses have been implicated, including mumps, Coxsackie, influenza, adenoviruses, and ecoviruses, but attempts to identify the virus in an individual patient are often unsuccessful and do not influence the management. The diagnosis of subacute thyroiditis is often overlooked because the symptoms can mimic pharyngitis. The peak incidence occurs at 30 to 50 years, and women are affected 3 times more frequently than men. The patient usually presents with a painful and enlarged thyroid, sometimes accompanied by fever. There may be features of thyrotoxicosis or hypothyroidism depending on the phase of illness. Malaise and symptoms of an upper respiratory tract infection may precede the thyroid-related features by several weeks. In other patients, the onset is acute, severe, and without obvious antecedent. The patient typically complains of a sore throat, and on examination reveals a small goiter that is exquisitely tender. Pain is often referred to the jaw or ear. Complete resolution is the usual outcome, but late-onset permanent hypothyroidism occurs in 15% of cases, particularly in those with coincidental thyroid autoimmunity. A prolonged course cover many months with one or more relapses occur in a small percentage of patients. Subacute thyroiditis often follows 3 clinical phases. The release of thyroid hormone is initially associated with the thyrotoxic phase and suppressed TSH. A hypothyroid phase then ensues with low T4 and TSH levels that are initially low but gradually increases. During the recovery phase, the increased TSH levels combined with the resolution of thyroid follicular injury leads to the normalization of the thyroid function, often several months after the beginning of the illness. Relatively large doses of aspirin or nonsteroidal anti-inflammatory drugs are sufficient to control the symptoms in many cases. If this treatment is inadequate or if the patient has marked local or systemic symptoms, glucocorticoids should be given. Thyroid function should be monitored every 2 to 4 weeks using TSH and unbound T4 levels. Symptoms of thyrotoxicosis improves spontaneously but may be ameliorated by beta-adrenergic blockers. Anti-thyroid drugs play no role in the treatment of the thyrotoxic phase. Levothyroxine replacement may be needed if the hypothyroid phase is prolonged, but doses should be low enough to allow TSH-mediated recovery. Relatively large doses of aspirin or nonsteroidal anti-inflammatory drugs. Painless thyroiditis or silent thyroiditis occurs in patients with underlying autoimmune thyroid diseases and has a clinical course similar to that of subacute thyroiditis. Typically, patients have a brief phase of thyrotoxicosis lasting 2 to 4 weeks, followed by hypothyroidism for 4 to 12 weeks, and then resolution. The condition occurs in up to 5% of women 3 to 6 months after pregnancy and is then termed postpartum thyroiditis. The condition is associated with the presence of TPO antibodies antepartum. It is also 3 times more common in women with type 1 diabetes mellitus. As in subacute thyroiditis, the uptake of the 99-technetium pertechnetate or radioactive iodine is initially suppressed. In addition to the painless goiter, silent thyroiditis can be distinguished from subacute thyroiditis by a normal ESR and the presence of TPO antibodies. Glucocorticoid treatment is not indicated for silent thyroiditis. Severe thyrotoxic symptoms can be managed with a brief course of propranolol. Thyrotoxine replacement may be needed for the hypothyroid phase but should be withdrawn after 6 to 9 months as recovery is the rule. Annual follow-up thereafter is recommended because proportion of these individuals develop permanent hypothyroidism. The condition may recur in subsequent pregnancies. The most common clinically apparent cause of chronic thyroiditis is Hashimoto's thyroiditis, an autoimmune disorder that often presents as a firm or hard goiter of variable size. Riddle's thyroiditis is a rare disorder that typically occurs in middle-aged women. It presents with an insidious painless goiter with local symptoms due to the compression of the esophagus, trachea, neck veins, or the recurrent laryngeal nerves. Thyroid dysfunction is uncommon. The goiter is hard, non-tender, often asymmetric and fixed, leading to suspicion of a malignancy. Diagnosis requires open biopsy, as fine needle aspiration biopsy is usually inadequate. Treatment is directed to surgical relief of compressive symptoms.